this is a panel discussion, and what we've done is to solicit questions from families from around the world, CDG families. And so the idea is there's a collection of people here who think they can at least answer some of the questions. So what we're going to do is sort of paraphrase the kinds of questions that have come in, because some were overlapping, and then individually we'll go through and answer those. So one of the things that came up that was we thought pretty important was, is there anything that's being done for therapy? And that was in relationship actually to CDG 1A, but it applies to other disorders. And so I think, Thorsten, why don't you sort of recapitulate perhaps the kinds of things that you know about, and then Phil, maybe you can add a little something more to that.
Okay. Well, as you've heard from the talk, there are quite a few efforts going on in order to influence the glycosylation, the hypoglycosylation, and by adding sugars that are affected in the pathway. And already there are some things where we can have positive results in terms of biochemical improvement as well as clinical improvement. And I'm pretty sure that's just the beginning, and it will turn out that we have, more than one sugar pill, maybe with an add-on medication in order to try to improve the symptoms the children have. Want to add something?
Yeah, I just add one comment to what Thorsten said. And of course, we get very focused on disease-modifying or curative therapy, but I think it's very important that we are also very aggressive about treating people with the tools that we have. And I think we can make a great deal of difference to the quality of life of children and adults by making sure that we don't neglect the common problems they have. Because I suspect there are a lot of parents here who've had the experience I've learned about over the years, and that is many physicians are scared of these diseases, and that anything that happens to a child or an adult who has one of these diseases gets attributed to the rare disease for which there is, quote, no treatment, so nothing gets done. And I think that's a huge problem, and these children, in fact, are more susceptible to infections. As children who have neurological problems become less mobile, they get into trouble with constipation. They need physical therapy. And I think attention to all of these things makes a huge difference. And I think one of the things as a community that would be helpful, we've talked about this, would be to publish, to develop some guidelines about management, to publish these, because I've been involved with other diseases where this has been done, and that's a useful thing you can give to your physician. So it's a roadmap for them to help in treatment. But I think it's very important we don't ever say there's no such thing as an untreatable disease. There are physicians who are nihilists, but there are no untreatable diseases. There are not many curable diseases, actually. Now, I think it's very important to work on the disease-modifying therapies, which Thorsten presented and which Hud and our colleagues are doing, but everyone is treatable, and there's something we can do. And if I can just make one final comment, there's a very good example of this that everyone's aware of, and that's cystic fibrosis. Now, very recently there was a paper about a disease-modifying therapy, but there's been nothing until that. No disease-modifying therapy, and yet when I graduated from medical school 31 years ago this year, most children didn't survive the teenage years. Now the mean survival is in the 40s, it's getting up close to 50. And that's without a cure, but it's because specialist centers have been developed, people have been aggressive about treating the disease, and recognizing there is a lot that can be done. So I think that's a very important message that we have to take on board and disseminate amongst the group.
Well, especially for CDG1A, I would like to add one thing, and that is fever. Fever is very dangerous for the children, and many of the complications occurring in CDG1A are associated with episodes of fever. And we know for sure that if you have no activity of the phosphoramidite that is affected in this disorder, that is not compatible with life. And there has been a nice publication where someone has expressed the different common mutations of children with CDG1A in a bacterial system and has shown the temperature dependency, and has shown very nicely that, you know, if the temperature goes up to 40 degrees, the residual activity, which is already very low, goes down close to zero. So for those children having CDG1A, at least, be very careful that your children don't have fever for too long. Give them medication early on, go aggressively to lower it. I think that is very important.
And that brings up one other point. I mean, Thorsten talked about treatment for 1A and mannose. And I think one of the things that we have to caution in all of this is, while that's very exciting and better than we've seen before, there's the possibility it will not apply to all patients, because it may be, as Eric was talking about, mutations. Different mutations will respond in different ways. And at the moment, we don't know. We can be hopeful. There are ways to check that out in the laboratory. And, you know, if funding comes along, you know, we'll do that. We'll try to predict which patients might respond, but the patients may fool us and tell us in the lab what the right answer is. But just be aware that, as hopeful as we may be about therapies, they may not work equally well on all children. Phil?
Well, one of the thing that I've really noticed is how UHUD have kind of put together this symbiotic relationship of basic science researchers, clinicians, families, and have brought to the forefront the idea of glycosylation and rare illnesses on many venues, like particularly the SIMD and other kind of genetic meetings. Because CDG, I'm also a neonatologist. I started out taking care of preemies, and I have to say that I don't think I'd ever heard of CDG when I was training, which I think was 31 years ago also.
I have to think about when
The term wasn't even used then.
That's absolutely correct. And CDGs are not really disorders that are thought of that significantly by physicians when they're evaluating children who have challenges. And I think it's through the dissemination of information through conferences like this and other kinds of meetings, but also through the social networking. I know that there's a Facebook site for CDG, and there's also the .org. I'm blocking.
CDG Family Network.
Yes, yeah, exactly. Where there's an opportunity for families to share their experiences of their children or friends or relatives. And I think it's through these kinds of conversations that we all kind of move forward. It's also very essential for general pediatricians to know things about this, because they may see children initially who have dilemmas, and they need to know how to make the appropriate referrals to the appropriate specialists. And perhaps they will refer them to a neurologist. The neurologist may or may not have familiarity with CDGs. And so it's really through these communications and interaction with metabolic specialists that we can kind of find more children, because we really feel that there are more children affected with these conditions that are really known.
I think Phil answered one of the questions, which was making the point, quoting Jacques Jakin, who'd said, you know, any child with an unexplained syndrome should be tested. And I think that awareness is growing, and I think all the things you said are important. Meetings like this, the social networks. Speaking as someone who's been an examiner for the American Board of Psychiatry and Neurology for a long time, I can tell you that one way to make particularly younger doctors focus is that they know there's going to be a question about this on their board exam. This is a really good way to get people interested in these diseases.
And you know, of all of the tests that physicians can order, the CDG, the basic transfer and glycosylation test, is one of the cheapest. It's certainly, depending on the lab, several $100s. It is not like it's not as expensive as a karyotype. Certainly, orders of magnitude less than a microarray. many orders of magnitude less than a brain MRI scan. So I think it has, at Children's, we order it often on little ones, but the pickup rate is low. But if you do pick it up in a child, you can perhaps, make a difference.
Do you want to say anything about any other aspect of therapy?
Would that be okay, Meow? Would it be okay for me to talk about? I mean, there's a subtype of CDG that we recently found through work that Dr. He in Atlanta and Dr. Freeze here in La Jolla, that isolated skin fibroblasts responded in a very favorable manner to mannose. Mannose is really this key sugar which is in our diet. It's also available in health food stores, as you know, to help supposedly reduce urinary tract infections. And what Dr. He found in tissue culture is that the cells utilized, at least in this one patient, in a very effective manner, and the abnormal glycans, as we call them, the polymers, little beads on a chain of the sugar, that the abnormal ones went down, and so the ratio of abnormal to normal was improved. And so we're ongoing with a single patient trial of mannose in this one subtype. And it's too early to say anything, and of course it's also not possible to extrapolate to other children, but in the same manner as Thorsten doing with the 1A with the mannose and the metformin, I think we just need to try these things. And I mean, mannose was only felt to be effective in 1B. I mean, that's what I learned when I did my fellowship, and fucose for type 2C, and that was the end of it.
And again, we're working on some of these patient cells within the lab to see, again, if we can make predictions about some of those that may respond to mannose or not. And whatever we find in the cells may or may not apply to the patients. But both of those arms, the basic science and the metabolic, patient-oriented stuff, has to be done.
But, one word of caution, though. Yeah, I think it would be very unfortunate if, families and parents would go and just buy mannose and try to give it to their children in order to get some improvement of the disorder. There are 2 points I want to make about it. First of all, one of the bad things is that we as a small community who have to collaborate together in order to improve things will not learn anything if someone does it on their own. Without sharing the data with others, right? And second of all, and that's much more important, is that it might be dangerous. Yeah, be aware that it is just simple sugars we are applying. But for instance, if you give mannose to honeybees, they will die from it. Yeah, and the only reason is they have no enzyme deficiency. They have just a slightly different balance in the enzyme activity of the same enzymes we have as well. So I'm pretty sure that if you give some kind of this, if you give these sugars to the wrong person, right, they may be even harmful. So if you want to do that, please contact someone who is experienced with these disorders and try to do it in collaboration with them, so that we can make sure that there's no harm done by it.
One thing I reported on last year is that mice that have a particular deficiency that resembles, at least in terms of the enzyme, one of the CDGs, if you give that mannose, if you give a pregnant mom, mannose, the embryos will die. Those that survive, half of them will be born blind. So this is really a cautionary note. Is that going to apply here? Do we have to worry about it? We don't know. Mice are not people. But what Thorsten says is absolutely true. We need to do this in some coordinated way. So please do contact us.
I have far less experience than you three gentlemen, but the one thing that I've observed in I know, as you likely know, these proteins that have the sugars on them, the glycosylated proteins, there's tens of thousands of them. They're involved in the blood, obviously the brain and muscle, from your toe to your nose and everything in between. And the mannose or other simple sugars that are in our diet or as additives to medications, they may help some of these proteins. They may actually harm us because there's multiple effects going on with multiple hundreds of proteins, and so the increase of one may be above the increase of another, and that could have a detrimental effect, particularly in things like the coagulation pathway, that you might have an effect where there's now not a balance between thrombosis and hemorrhage, but you might have an individual who's going to have a significant bleeding episode, or they may clot in some place that would be very hazardous. So absolutely, we have no idea how it's going to work out. It needs to be done under the guidance of a physician. And this is a complete team approach. I mean, people are working together and in collaboration and having discussions amongst ourselves.
There's a couple of good questions that address an issue about about predicting the phenotype, or in other words, the physical and disease characteristics of children with CDG1A. It's a very good question. A couple of things to address. One parent had said, gee, I know all kids are missing the same gene. Well, children with CDG1A all have mutations in the same gene, but they have different mutations. And as you've heard from the talks earlier today, different mutations affect the protein differently. So that's one source of variation. But another question that flowed from that was parents who already have a child who's affected relatively mildly and are saying, can you predict, if we have another child who's affected, whether that child will be the same? Unfortunately, the answer is no. You may say, well, why is that? Because that child must have the same 2 mutations in that gene. But I think the important point, again, which came out from the earlier talks, is when you're looking at a whole person, it's not just the effect of that one gene. It's a very important gene, but there are thousands of others. And there are surely genes, we know there must be other genes that modify the disease. And so siblings, brothers and sisters, have very similar genotypes, but they're not identical. And it may be that, another sibling will lack a particular gene or have different expression of a gene so that you get pronounced differences. And we've all seen this in these recessive diseases where we do have families with multiple affected children. Now, the sort of general rule is, yes, they're usually much the same, but that's not always the case. And sometimes there are very big differences. And we don't yet have the tools or the knowledge to be able to predict that. So that's hard, but I think that's the reality.
Yeah.
One of the questions, I think, in a nutshell, was if we as parents have one child with CDG, whatever subtype, what is the chance of another child having CDG? And the general rule of thumb is that if both parents are carriers, meaning that out of the 2 copies that they have, we call them alleles, that a parent would have one broken gene or mutation, and each would be a carrier, and therefore there would be a 1 in 4 or a 25% chance that each child would have the condition. And a lot of families might think, well, we have one affected child, the first child, so that means the next 3 are going to be okay because out of 4, it's just 1 out of 4. But unfortunately, each subsequent baby has that same 25% chance. But it actually brings up a very important thing that should be done to assess the full risk, and that is that parents need to have targeted mutational analysis to make sure that they're both carriers, that one can't really assume that. And the reason is that one parent could be a carrier and the other parent could have one of 2 things, either had a spontaneous mutation in either the egg or sperm that made that first baby, or there could be something called gonadal mosaicism, and that means that the mutation is hidden within the germ cells of that parent, but it cannot be detected in the blood because the blood comes from the bone marrow, which is a different tissue than the ovary or the testes. So those are considerations that would be important to always discuss with a genetic counselor or your geneticist slash metabolic doctor.
We're just about running out of time. Is there anything anybody else wants to add here?
Maybe someone has an urgent question from the audience.
Then how about the other subtypes? And for more possibly useful. Those phenotypes. Then currently, I think a lot of time we really don't have for those rare subtypes.
Yeah.
To be sure that we get this recorded, the question was basically about natural history of CDG1A. We got a lot of patients. We don't have very many patients. And the other types, what do we know about the other types and their natural history, and is there any coordination? That's the question.
Yeah. Well, I would like to make a comment to that. And that is, you know, if you look at the scientific papers that have been published for the rare subtypes, 95%, if not more, of the paper is about biochemistry and genetics, and you have just a few sentences about the clinical phenotype, which makes it extremely difficult for a doctor to recognize these disorders on a clinical basis. And then there might be an extreme phenotypic variation. I mean, of two of the glycosylation disorders we have where we have found the molecular defect and described in the first place, I can tell you that subsequently I had two different patients where I did not recognize the subtype, although I had made the previous description, right? Which tells you that we have way too little information about the clinical phenotype, and I'm sure if we have more patients and if we collect this data and especially make sure that we have more detailed clinical descriptions of these patients, that we will be much better in distinguishing the different subtypes already on a clinical basis. We don't yet, but we should. Yeah. Yes.
Is there a registry? No. Should we have one? Yes.
Yeah. Yeah.
I think we're going to have to wrap it up here. I appreciate everybody's contribution. Thanks for everybody on the panel. We'll be around, all of us, today, and we're also here tomorrow morning. The families know about this. We're here from 9:30 to about 11:30, something like that, so families can come and ask questions. So if you've got other things, please come. We'll have some refreshments, and come ask us questions, okay? And I think we're going to have to go on now to the rest of the program. So thanks, everybody, for your questions.
It's not every day I get to sit next to Harrison Ford.
Not up on your glycobiology.